Welcome to NCPDP Unscripted, the podcast where healthcare meets real talk. Each episode, we will dive into unscripted conversations with industry leaders, changemakers, and innovators discussing the challenges, breakthroughs, and behind-the-scenes stories you won't hear anywhere else. Whether you're on your morning commute or taking a break between meetings, settle in because it's time to get unscripted.
All right, well, we are here at NCPDP Annual Conference 2026, and I'm super excited to have Anu Kaur with us, joining us today on NCPDP Unscripted. So welcome.
Thank you.
So you did a presentation here at our annual conference yesterday about electronic prior authorization and AI. Is that correct?
Yes, that is correct.
Fantastic. Well, we're going to dive into that, but first, would love for our audience to get to know you a little bit. You're a pharmacist, but you are on the business side now. So just tell us a little bit about what that journey looked like.
Sure. First of all, thank you so much for having me here, Pooja, and thank you to the NCPDP team. My name is Anu Kaur. I'm a clinical pharmacist by training and currently at Conduent's product and technology team. I've been a pharmacist for the last 8 years and transitioned into managed care. I've been a pharmacist for the last 8 years, but I've been in the pharmacy field for over 20 years.
Okay.
And I started at behind the pharmacy counter, then moved my way up into managed care, health plan, specialty pharmacy, and currently working in the role of technology solutions consultant at Conduent.
Oh, so you've seen it all the different areas.
Seen different pharmacy areas from
Yeah.
all different angles.
Yeah,
Yes.
I'm sure that helps in what you're doing now as
It
well.
does help a lot.
Yeah,
Yes.
that's great. Fantastic. So, given your clinical background and just all the different areas of pharmacies that you've worked in, how has that kind of shaped your approach to, really access and workflows and even transparency?
Sure. So it all started me behind the pharmacy counter, and I kept seeing the same patterns over and over. It wasn't because, as a pharmacist and working in the pharmacy, we didn't have the drug. It wasn't that the prescriber didn't send a prescription. It was almost at the point where something broke in the system, and that something was either a prior authorization was pending, or a claim was rejected, and we kept seeing over and over the patients walking away from the pharmacy without the medication in hand. So at some point, I started thinking it's really not about filling another prescription or filling a volume of prescriptions. It's about where in the system can we fix or work on so that we can make an impact to thousands of prescriptions. Because a single configuration in a pharmacy benefits management system can cause thousands of rejects.
Yeah.
So it's just a single configuration. So that's what prompted me to move into the pharmacy benefits management space. And my work at Conduent is actually really shaped my interest in the electronic prior authorization and prior authorization workflows in general.
Yeah.
Because at that point my understanding was it is really not a workflow problem. It's a problem with the standardization of the data and standards, and that's what got me interested in NCPDP as well.
That's great. Yeah. And so let's switch to that topic, prior authorization.
Yes.
Big focus.
Yes.
CMS just put out a proposed rule, which I think you've read as well, about having the pharmacy prior auth with the NCPDP standards, the medical prior auth using FHIR, and I think that's kind of the smart way to do it. But what stands out to you if you did read the proposed rule and kind of like where we're seeing CMS go with that?
Sure. Thank you for that question. It's a hot topic at the moment, along with electronic PA, EPA. What we had, or what it all began with, was a few years ago, February 2024, when CMS actually published the CMS 0057 rule. They finalized that rule, but excluded the drugs from that rule. So the industry, vendors, everybody was working towards a solution for non-drugs and non-drug items and medical services. With this release, or this proposed rule now from April 10th, now drugs are coming into the picture. It is still a proposed rule, but it may get finalized, and if it does get finalized, we have about just 18 months to go. And how I see this happening is because the rule specifically names that impacted peers need to be supporting NCPDP script standard, as well as the real-time prescription benefit and the formulary and benefit standard. So a few years ago, that was a good to have, a recommendation, and very soon it's going to become a part of a requirement for the impacted peers. That's one. Second thing that stood out to me was the turnaround times, that they have specific turnaround times. Of course, it's pair specific for our purposes, or for Medicaid specific, let's say. For example, Medicaid would have 24-hour decision timeframes, turnarounds for all drugs, all drug PAs, versus some other types of payers would have 24 hours for expedited, but they still have, I believe, 72 hours for standard requests. So that was another thing that stood out to me.
Yeah.
And finally, I believe there is also a requirement or a note in the rule that I read that the CMS actually wants to see your metrics.
Yeah.
The metrics you're reporting, they want to see your API endpoints for peer-to-peer, for patient access, for provider access, the information provider can access may be different from what the information the patient is able to access.
Yeah.
So they are wanting that clarity, which we did not have until now. So that's not being part of a regulation, a possible regulation, is what everybody is going to work towards.
Yeah, no, it's great. And I think, the way you started out by saying you wanted to make a real impact, right? Like, I think with this rule, this proposed rule, we're hopefully going to start seeing that, if people start
Absolutely, yes.
implementing.
And I did briefly mention during my presentation yesterday that when I finalized that presentation, it was between December of
Right.
2025 and March. I did not expect a ruling
Right.
or a proposed rule to come out 15 days before my presentation.
Yeah.
But that was amazing and great work. And let's see, once the comment period closes, June 15th, where the industry is actually standing.
Yeah, no, we've been waiting for this rule for a long time as well, so
Absolutely.
that's great. So I do want to dive into what you presented on. I know, you were kind of looking at how AI can help with prior authorizations.
Yes.
So would love for you to dive into that a little bit.
Yes, sure. So AI in the context of prior authorization and electronic prior authorization, where I see that coming into picture is we get payer coverage policy documentation. AI tools are even currently being used to extract information, medical history information, diagnosis, lab values, patients' trial and failure of therapies. So once the AI tool extracts that data information, or that's the first layer, is what I call, is then the second thing is how do we use that information, and that's where I see a clinician comes in, or is able to differentiate between the information that's useful and information that is not useful. Because at this time, AI cannot make that determination as I understand it.
Yeah.
But it does still have a role to play because AI is how we are going to be able to scale the electronic prior authorization among different vendors, among talking with each different systems.
Right,
So
yeah.
that's another point for AI tools. Use of AI tools is being able to get that layer on the top of the foundation that we already have in the form of NCPDP standards, the script standards, the FHIR standards, and other low-ink and RX norm terminologies, that medical standard terminologies that we have. Now we will be using them more
Yeah.
instead of creating our custom codes.
Right.
Yes.
Yeah, that's fantastic. That's great. And I know we're also here at NCPDP talking a lot about like what can we do, with AI. And one of the first use cases that is coming out is around prior authorization. So,
Absolutely.
in the next couple months, folks can be looking for that. So, kind of looking ahead, are there other areas or ways that you can be thinking of, or that maybe you guys have been focused on to kind of improve the prior authorization process, in other ways as well?
Sure. So some of the ways that have been currently in place already and some that could be improved upon is, and also I believe AI will have a role to play, is monitoring the turnaround times. So even if we are bringing AI into the electronic PA solution, how is this going to really, is this even going to affect any current processes, or is it going to increase burden where now we have to now assign two clinicians to evaluate the output from the AI tool?
Right.
So that is another, so monitoring the turnaround times, monitoring the appeals process. Are we seeing increased volume of appeals? If that is, then that needs to really go back to the policy review. The AI output needs to go back to the policy review, not just for a single instance or single PA
Right.
appeal.
Yeah.
So that would be very helpful, that we don't treat AI output for, for every single PA differently, but we take that output and bring it back to our policy tables to see what else can, why did AI make that determination, and what is the reason for every appeal request that we receive from the providers?
Yeah.
Why did they make that appeal? Was it because of a decision AI made? Was a human involved in the judgment?
Yeah.
That sort of workflow is what I see, anticipate more
Yeah,
as
that's
we
great.
dive into AI.
Excellent, fantastic. Well, we need to wrap up. I think we could sit here all day and chat about this, but just in kind of the final minute, what are you hopeful for? It sounds like you kind of got into this, wanting to really help the patients. Do you feel like we're going to get there?
Yes, so at the end, it's about the patient. It's also about the provider. I wouldn't say, providers are, of course, electronic PA, but it's reducing that provider burden. We hear that all the time,
Yeah.
right?
Yeah.
But for every problem, every solution that we are seeking, we're looking at, we need to take a step back and think from the provider's perspective and from patient's perspective too. Every solution, and it's for everybody, not just for PBM, not for just payers, and not for our regulatory bodies.
Right.
It's because on the other side, there is somebody's 90-year-old mother who is waiting for their pain management therapy,
Yeah.
or for their cancer therapy. And once we get into that perspective, then things shift. Things
Yeah.
start to shift very soon. So
Yeah.
that's what I'm hopeful for, is that we are headed into the direction, and sooner or later we'll get there.
That's excellent. Well, Anu, thank you so much for joining me
Sure.
on the show. And yeah, look forward to kind of following the work that you guys are doing. And we'll see where this proposed rule ends up as well.
Thank you so much, and thank you to the entire NCPDP team for giving me this platform.
Yeah, absolutely.
Thank
Thank you.
That's a wrap on this episode of NCPDP Unscripted. Thanks for joining us as we explore the voices and ideas driving innovation in healthcare. If you'd like to be a guest on the show or have topic ideas you'd love to hear us cover, we want to hear from you. Until next time, stay curious, stay connected, and stay unscripted. Our podcast is proudly sponsored by Marks Productions.